Landscape Live Connect platform by scanning the QR code on the front of the agenda at your seats. Joining the platform is the method you use to ask questions, to follow the slides, and participate in the polling that we'll do. We encourage the virtual audience to ask questions and participate in polling as well. I want to remind you that we have a Wi-Fi network here. You can see it. It is shown to you here. You can connect through that to allow you to use the app. And there's the QR code for downloading the app. Just a reminder also for our virtual audience to use that app as well. So welcome to our symposium, Shaping the Future, the Evolving Role of the Radiation Oncologist in Lower Grade Glioma Care. My name is Eric Solman. I'm the chair of the Department of Radiation Oncology at Duke University, and I'm joined today by some very esteemed colleagues. To my far left, Dr. Mitch Berger, the director of the Brain Tumor Center at UCSF, an esteemed neurosurgeon. Coming in from him, we have Dr. Ben Ellingson, professor and director of MRI research at the UCLA Brain Tumor Imaging Laboratory. Then Dr. Leah Hallis, professor of neuro-oncology, radiation oncology at Fred Hutch. And finally, Dr. Michel Weller, professor and chair of the Department of Neurology at the University Hospital in Zurich. We have a very full agenda, and we're going to cover a lot of ground, including some cases that we'll discuss at the end, where we'll have plenty of opportunity for interaction from all of you, both here and online. So I'm going to give just a very brief introduction and remind you of the treatment approaches we have for patients with IDH mutant gliomas. We really have decades of experience using radiation in cytotoxic therapies like temozolomide and PCV-based regimens. We have randomized data to support the use of multiple modalities, so radiation followed by chemotherapy, for example, that show improvements in patient survival. Our treatment decisions based on these data are really from the pre-IDH era, trials that really began in the 90s, and sometimes resulted in a lot of controversy as to whether to do observation versus upfront therapy versus what to use at salvage. And as I said, these data were really built before we knew to even look for IDH mutation. Indeed, molecular pathology has evolved faster than we've been able to run clinical trials, largely because it takes decades to run these clinical trials. So now new targeted IDH inhibitor therapy with FDA approval based on progression data has emerged, and it's really the first approved targeted therapy in the treatment of patients with gliomas. So many questions remain, and we're going to address those as best as we can tonight with this panel. First, who to select for IDH therapy, inhibitor therapy? When is it appropriate to use upfront cytotoxic therapies like radiation and chemotherapy? And when is it appropriate to use upfront IDH inhibitor therapy? What is the best therapy to use at salvage? What is the best combination of therapies? What really, I think for all of you here that treat these patients, what practical criteria can we use to help make the decisions and which you can bring to a multidisciplinary conference or tumor board? So I'm now going to hand over to Dr. Weller.
Thank you very much, and good evening from my side. My disclosures are, I don't have a US passport and I'm not a radiation oncologist, so I'm going to insert some European spices into the evening. But in principle, I think the situation is similar. I was still a bit surprised about the title of the emerging role of the radiation oncologist, because I think in Europe, the feeling is more that they have to redefine their place with all these competitive treatments on the horizon. So I'm going back to 2021. That's the WHO classification. If you go from left to right, the prognosis gets worse. And in 2021, the IDH mutation has really been placed at the apex of the classification and is the first thing you ask for in the diagnostic process in gliomas of adulthood. And I think that the evening will be dedicated to adult patients. And after 2 decades of discussing with pathologists whether something is an oligo, an astro, or oligoastro, the truth is now that we make very little difference in treating them. We treat according to the IDH mutation status. So the fact that the IDH mutation comes early on as a driver suggests that it is important. And there are a lot of very exciting, interesting theories of how this works. I think the truth is that we don't know. What we have summarized here on the slides are several hypotheses, but it remains all hypothetic. And as we go along, we will discuss a little bit about the data on IDH inhibition. And if you observe the MRI scans in these patients, you certainly don't see massive changes, which I think argues against massive necrosis, massive inflammation. It must be something more subtle that is induced by IDH inhibition. Importantly, this is a gain-of-function mutation, which means that if you could inhibit this function specifically, it should be essentially without side effect, because none of you should have any mutant IDH protein in your organisms. So that is, in principle, something nice to have for a targeted treatment. When the WHO classified the astrocytomas back in 2019, 2021, they, of course, did not anticipate how important this challenge would be between the grades. Now we all know that it has become very important if suddenly the grading determines whether you get a treatment or not. And this reminds me a little bit of the good old times with PCV, when suddenly the pathologists saw oligos everywhere just to make sure that patients could receive PCV treatment. So the WHO makes these 3 differences. This is the original slides from the WHO. And of course, experts can see that. I guess for you, it would be a little bit more tricky. And the borderline between grade 2 and 3 is not very well defined. There is no quantitative threshold. It's much easier to distinguish grade 3 and 4 because there are the criteria of necrosis, of vascular proliferation, and the molecular one of CDKN2A loss. And already at present, there is a working group that's trying to improve the distinction between grade 2 and 3 for the upcoming WHO classification. And I think you are all aware of the fact that the distinction is not easier for the oligos. Now, we have also been looking at that in a big German study. And this study was actually designed to characterize the grade 4 tumors better, because we didn't really know so much when the WHO created this IDH mutant glioblastoma replacement and calling them grade 4 astrocytoma. But it was a nice opportunity to see whether on central review there is a difference between grade 2 and 3. And in the middle figure, you see that at least for the German pathologists, there is a clear difference between grade 2 and 3, and they were blinded for the outcome. And then on the right, you see something important that I think necessitates a change in the WHO classification. If you simply look at grade 4, and then you ask whether CDKN2A is lost or not, you see a massive difference. So if CDKN2A is lost, you essentially look at a prognosis that is like glioblastoma. And I think that this will somehow enter into the new WHO classification, and maybe we will then have also 4 grades for these tumors. So let's go to clinical management. I think we tend to agree now all that whatever tumor tissue can be taken out should be taken out, and I would not dare to say something differently if Mitch Berger is sitting so close to me. The key question in the last decades has always been who should be treated beyond surgery. And the typical position of neurologists is always defer, delay radiation as long as you can. And the clinical trials have clearly told us that if you make the decision to go beyond surgery, then it has to be combined modality treatment. That is evidence that cannot be disputed, and that is true for grade 2 and 3 and for oligo and astro. And then if you look, if I look critically at our own guideline and look at what we have written there, the first criterion is age. We say age of 40 plus is a poor risk factor. However, this is not true, and we really didn't look at the data carefully enough because, as Eric Salmon has indicated before, all these recommendations are based from the pre-IDH era. And the reason why age is so important is not the age per se. It is the contamination of mutant glioma studies with wild-type patients. And if you look simply at the IDH mutant population, this age effect is gone, and it will be gone in the next classification, in the next of our guidelines in Europe at least. And then what you see there as well is if there are neurological deficits, you should treat. And if there is residual tumor, you should be considered high risk. And this is what radiation oncologists have been considered as their domain for decades. Now, I want to briefly look at the INDIGO clinical trial design, because the design of this trial is already a first, let's say, opposition against the guidelines that is now and has been heavily discussed, notably in the radiation oncology community. If you look at the inclusion criteria, then there should have been residual tumor. And if you look at the guidelines, patients with residual tumors should be treated. And on almost all conferences where I go, where radiation oncologists are sitting, they raise their hand and ask for the logic of this design. But I must say, if a clinical trial enrolls so well and is against the guidelines, then maybe it is the guidelines that need to be changed. I think that is open for discussion. In any case, this was a clinical trial that was difficult to enroll. Many sites have done very well. We, for example, have not managed to put a single patient on the trial in Zurich because it was difficult to communicate to the Swiss Germans that you randomize somebody to placebo who has residual tumor. For us, it was really difficult. But in other centers, that appears not to have been a problem. Now, this is the outcome. It's clear it's a positive result. You see the effect, you have seen it before. That's progression-free survival. You also see that it's not really a curve, but you see it's more like a staircase, which means each time that an MRI is done, patients are taken off trial. They are not taken off trial in between, because most of these patients are in relatively good shape. It's important to understand INDIGO. It's a selection of very good prognosis patients, except for the residual tumor. Now, what do we do with the clinical trial results? My colleague to my left will discuss a little bit more about the results, but clearly, the role of IDH inhibition must be placed somewhere between the wait-and-see strategy and our feeling that somebody needs real radio-oncology chemotherapy treatment. So our agencies have given us the answer, and it's very interesting to see how they word it. In INDIGO, you needed to be off the last surgery for at least 1 year, but none of the agencies have taken up this criterion. Grade 2 was INDIGO, and the agencies have also made it grade 2. And when we prepared the slides, I was still a bit biased towards my home country, Switzerland, but last week the European Union also approved vorasidenib. Took a little bit longer, and the definition is very similar. And then what they have done, and clearly worded in the Swiss approval, is that they play the ball back to us. They say, you have to decide who needs immediate chemoradiotherapy. It's not going to be a regulatory agency. Some think this is coward behavior. I think actually it's good that we have a little bit of autonomy to decide who we think should be treated or not. I have to cite this one letter, and maybe the colleagues are here in the room or they are out there in the internet. So these colleagues wrote this letter that made the IDH inhibitor community a little bit nervous. And I encourage you to read it because it's really well written. And there's two ways of looking at the problem. You could argue, well, the colleagues are right. They have read the guidelines, and they say indigo opposed, violated the guidelines. The other way of looking at that is to tell the colleagues, look, you have not really understand how we did the trial, because the idea of IDH inhibition, again, is to delay radiation. Now, what we will not cover in great detail is that, of course, the reason to delay radiation is always the concern of toxicity. And there is a lot of data now out there that, to me, suggests that there is at least as much toxicity induced by the tumor as by the treatment. So we need a balanced view of who is causing how much loss of quality of life in this patient population. This is from a recent consensus paper where we stand at the moment. We have at least 3 options to consider. If we have a complete resection, the approval would allow us to treat with IDH inhibitors, but I would say we don't have to if there is no residual disease. If we have residual disease, I think we should consider vorasidenib. I'm also not supporting seeing residual disease and not treating at all. And then is that now to us to decide in modern times what is a high-risk patient. For me, it's certainly somebody with stable neurological deficits or progressive neurological deficits. I would not put somebody with incipient aphasia on an IDH inhibitor, because I would be concerned that I cannot reverse neurological side effects, deficits, once they have occurred. Where do we go beyond the IDH inhibition? This is just one slide, my final slide. Obviously, the key question now is, how do we integrate that with the standards of care? Would we have additive activity if we combine it with radiation and chemotherapy? Are we sure that radiation will work as well as before if patients are pre-exposed to IDH inhibitors, or even better? It's all important questions that are now going to be addressed in clinical trials. And then, if it is true that part of the effect of IDH inhibition is to revert immunosuppression, it's clear that they should be combined with checkpoint inhibitors in experimental trials. Vaccination is a topic. And what we focus on is also a lot of drug repurposing for these tumors, because if you think beyond boring old alkylators and IDH inhibitors, there are not very many novel developments on the horizon. With that, I would like to close and give it over to Leah.
So thank you for the organizers for including me tonight. I am going to speak on looking at some of the key supporting clinical evidence we have for IDH-targeted therapy. Like Dr. Valera, I was going to look at what we have in our guidelines and where IDH mutant inhibitors will fit. This really also allows us to kind of articulate what additional trials are needed, what questions are, and really think about how we personalize radiation therapy in this new treatment paradigm. So starting with the pre-IDH mutant inhibitor era, I always think it's important to remember that our patients with grade 2 and 3 IDH mutant glioma have long median overall survival estimates, so greater than 10 years for those grade 2 and 3. And so when I meet a patient up front, I often think about those many years in front of me, hopefully for most of those patients. And this is kind of a schema of what we had before IDH mutant inhibitors, where diagnosis is made at MRI and surgery. And then for many patients, if they have a gross total resection, and we could then watch them and they don't have upfront treatment. But otherwise, we consider which patients need radiation therapy and chemotherapy for upfront. But many patients, most of the patients will recur, and at this point, there are various treatment options, clinical trials, chemotherapy, repeat surgery, reirradiation. Really unclear what we should do at that time, and really depends on what the patient received before and the timing of it. And then many years of follow-up. So about 2022, the ASTRO guidelines were published in this pre-IDH mutant inhibitor era. And I think one important point that I always like to make about guidelines is there are strict methods and there are conditional and strong recommendations. So the recommendation for radiation and chemotherapy for patients with grade 2 tumors that had subtotal resection or high-risk features was very conditional, and I'll explain why we came to that conclusion as our expert panel. So I think a lot of that is based on our legacy trials where we really looked at adjuvant radiation therapy for grade 2 glioma. Obviously, before the molecular area, we didn't know quite that they were IDH mutant at the time. But remember that early radiotherapy improved progression-free survival, but not overall survival for these patients. And we term it early radiotherapy because those who did not receive earlier radiotherapy, 2/3 of them eventually received radiotherapy in this trial. And much of what we know about how to treat these patients also came from RTOG 9802, which actually had two parts. Sometimes we forget this part, which was that there was initial observation for patients aged less than 40 with gross total resection, 111 patients. And what you notice from this is that the 5-year overall survival was very good, 93%. But the 5-year progression-free survival was 48%, meaning that many of these patients will go on to recur, but at a later time. So the other part of 9802 that we know well is that overall adjuvant chemotherapy in the form of PCV improved overall survival for those who were deemed high risk in this trial. That was age greater than 40 and or subtotal resection. We now know that age was not as important perhaps than when this trial, what we thought when this trial was created. But what's important about this trial that I always say is that both arms received adjuvant radiation, so it doesn't really speak to the observation versus treatment. So overall, our guidelines looked at the grade 2 tumors and again had a strong recommendation for surveillance for oligodendroglioma with grade 2 and no high risk factors, gross total resection, and then conditional recommendations for those that had high risk disease, astrocytoma, both recommendations were conditional. The grade 3 data, we come from different trials with anaplastic oligodendroglioma and anaplastic astrocytoma trials. Again, both of these, all of these trials had radiation in both arms, and adding chemotherapy improved overall survival. And overall, the panel felt that this was a strong recommendation for radiation and chemo for these patients. So as already discussed a bit, I think one of the things that is coming out much more and being spoken about is that grade 2 and 3 are not so different as the panel made it look like. And there's really a lack of standardized histological criteria. Sounds like we might get some more standardization in the future. And there are several retrospective studies showing lack of prognostic impact from mitotic count. So we kind of take this into account when we're thinking about patients. There's also kind of new data about spatial and temporal heterogeneity in tumors. So where then do we have the IDH inhibitor data now? So I think of it in sort of two buckets. One, we'll talk a lot about Indigo, obviously an important trial in this space. But then there are quite a few phase 1 trials that we lumped together that really looked at patients with recurrence. So these are 3 phase 1 trials, there are more, but to show some of the principles behind some of these trials for recurrent patients. These are trials that were looking at safety as well as looking at signal for efficacy. And it's important to note it was a mix of grade 2 and grade 3, and that most of these patients had prior radiation therapy, and most had prior systemic therapy. So some of what we learned from the phase 1 trials is that, one, there was actually great radiologic response of at least stable disease in those tumors that were non-enhancing, so 86 to 100%. For enhancing tumors, that number was lower, so 45 to 57% had at least stable disease. So we knew there was a difference in how these reacted on the imaging. We had good overall progression-free survival for non-enhancing tumors. In enhancing, it was a little more spread out, also perhaps due to a different patient selection. But importantly, there was overall very good side effect profile. So when looking at Indigo, I think one of the most important things to look at is who were the patients that were included in this trial. And the idea was that they very much wanted to see the effect of vorasidenib and the primary endpoint was imaging-based progression-free survival. So they very much chose a population where you could see that. So patients who had residual tumor, patients that were at least a year from their surgery, because within that year you might have post-operative changes on the MRI that are hard to determine and watch. And very importantly, they did not have previous radiation therapy. Also important because once you have radiation therapy, it's sometimes hard to figure out after whether you have tumor progression or you have treatment effect. Also important about this trial is it was grade 2 patients and lack of high-risk features. So these patients could not have symptoms that were clinically relevant. They could not have neurocognitive deficits that were clinically relevant or uncontrolled seizures. So these patients were randomized 1-to-1 vorasidenib versus placebo. And overall, at their second interim analysis for efficacy, they met their criteria. So the progression-free survival was increased from 11 months with placebo to 27.7 months with vorasidenib. At that point, they allowed for placebo crossover to vorasidenib. So this is with a median follow-up of 14 months, and really the data is immature to assess median overall survival. So as I said before, importantly, the safety analysis of this, it was a well-tolerated drug. LFTs were an issue for some patients, but treatment interruption or dose reduction really helped most. And so now with this trial, I think very much showed the efficacy of vorasidenib, but there leaves a lot of questions. So one, should this be used earlier or later than that time period with which it was used after surgery? Is this right for patients with gross total resection? And then the whole host of questions of higher risk tumors like grade 3, grade 4, enhancing disease, intractable seizures. It also did not answer what it would do to use some of these IDH mutant inhibitors with radiation and chemotherapy or after radiation and chemotherapy. And the whole question of recurrences and how to sequence this with our other therapies is still an open question. So there are ongoing clinical trials. Was not going to go into this in detail, but to point out that there are trials really looking at looking at it after chemo and radiation, and to also including combined therapies with immunotherapy and chemotherapy. Further, other trials with multiple different drugs also looking at these questions, and I think very important to answering some of those questions that we all have. So for us as radiation oncologists, I think it's very important that we now know this data, that we participate in the patient selection, and that we think about whether the response to radiation and chemotherapy after IDH mutant inhibitors is going to be the same as we're used to. And then finally, which is always the big discussion with these patients, is really weighing the risks and benefits of radiation therapy. So a few things that I see with some of the patients that I've seen on IDH mutant inhibitors is one, I think it's important to watch these patients closely and to consider that for what your radiation therapy field is going to be. Here's a patient who started in 2022, and I saw them in 2024 for the first time, and it just struck me that the field size would be a lot bigger. It had progressed posteriorly, and wondering how that would impact the actual toxicity and side effects of radiation. This is a nice paper that looked at tumor volume growth for grade 2 IDH mutant glioma under active surveillance, not necessarily from the Indigo trial, but from a time before. And what it showed is that the doubling time is 3.5 years. The growth can be slow, but as you can see from the plot, that these tumors can become large very quickly, and that impacted survival. So with each natural logarithm tumor volume increase, there was more than 3-fold increase in risk of death. The Indigo trial very nicely looked at the tumor growth rate as well, showing in red that they overall had decreased volume versus the placebo, and blue showing increase, though as you can see from the scatter plot that every tumor acts a little bit differently. But I also think it's important to really think about what we are trying to do in terms of delaying radiation therapy. So we're trying to delay radiation therapy in much because of its impact on patients' longer-term quality of life and neurocognitive function. But there's a lot of questions these days about, with the modern radiation therapy techniques, how much do we really impact the neurocognition? I think we do to some extent, but what is the overall reason? This was a series by the German Glioma Network where their conclusion is they prospectively followed patients for neurocognitive function much later, so 5 to 10 years after treatment. And in their series, they did not find profound changes in neurocognitive functioning in any of the treatment groups. And so patients generally retained their cognitive function after treatment. This is a nice systematic review that also looked at how a lot of our patients are really affected by cognitive impairment even before our treatments, and have that based on their tumor volume. So I think what's important here is we're talking about is that to know when patients have symptoms, to do good neurological exams, to figure out which patients would really benefit from us treating earlier and controlling that tumor rather than waiting. So this is the importance of radiation oncologists in the multidisciplinary care. We can evaluate the effects of radiation based on the anatomical location. We have knowledge of the modern radiation techniques. And I think very important to counsel patients about side effects, even if we're choosing to defer radiation. I was finding at first that a lot of patients would come to me very scared about radiation once they needed it after being observed. And now we see all these patients up front, even if we recommend observation. And it's good to follow your patients long term so you can really help them figure out what the side effects may be or the risk and how they may affect them. So I end with the ASCO SNO rapid recommendation that came out. This is where vorasidenib may be offered to people with either oligodendroglioma or astrocytoma grade 2, where after one or more surgeries, further treatment with radiation and chemotherapy can be deferred. And I think that's the very important patient selection that we should discuss in our multidisciplinary tumor boards. Thank you.
Thank you.
Now hand over to Dr. Ellison.
All right, thank you. So I'm going to talk a little bit today about advances in imaging for treatment planning and monitoring, much of which you probably are already using in your day-to-day routine. As we all know, imaging is really a cornerstone of patient care for patients with diffuse gliomas. Unlike other types of cancer like breast cancer, where we can test pathologic confirmed responses and really understand what's going on with the biology, on sort of a pathologic level, we really rely on imaging to really understand what's going on with these patients over time. And so in 2014, we met, a variety of us investigators met with the FDA and really came up with criteria for standardizing the way that we acquire images so we can really start to interpret how these things change over time. You can see the protocol here. It's been published. It's now 10 years old or so. But this is really the recommendations that we use for day-to-day routine following the patients with gliomas, as well as for use in clinical trials. It was also the protocol used for the Indigo trial. The first part of kind of the basic clinical MRI exam, I'm sure you're all probably aware, is the T2 weighted MRI. This is related to really the concentration of water. And it relates to the rotational mobility of those water protons. So the more mobile the water, the longer the T2, the brighter it is on these T2 weighted images. And so you see between normal kind of brain parenchyma and edema, we have tumor that is a little bit less water content. And on T2 weighted images, we can start to differentiate what's tumor, what's edema. Here you see in areas of suspected edema, you see the T2 hyperintensity go all the way against the cortical ribbon. It obeys the gray-white matter boundary. It doesn't necessarily distort the architecture, whereas that area of tumor, you can see degradation of the parenchyma. Again, can be really difficult to differentiate where does tumor start, where does edema start in these patients. Next is the T2 weighted FLAIR MRI. FLAIR stands for Fluid Attenuated Inversion Recovery, and the idea is that we use an inversion preparation to null the signal from CSF. And so it essentially suppresses the fluid, and so what we see is T2 weighting, and we can see nice lesion conspicuity against the subarachnoid space or against the ventricles, for example. And then lastly, like one of the most important aspects of the basic clinical MRI is really pre and post contrast T1 weighted MRI. So this looks for areas of where vascular permeability or where vascularity is really broken down, where contrast leaks into the surrounding adjacent extravascular space. That shortens the T1 of the surrounding water. It shows up bright on the post-contrast T1 weighted images. Post-contrast T1 weighted images showing contrast enhancement really captures the most aggressive component, and as we'll see, likely is related to malignant transformation in patients with IDH mutant gliomas. So these IDH mutant diffuse gliomas can have a variety of sort of disease trajectories, as was nicely illustrated before, kind of looking at volumes over time. These patients can have stable disease over a very long period of time. So this is a patient that was basically stable, very diffuse disease throughout the right hemisphere for 12 years post-radiation, et cetera. They also can grow very slowly and kind of creep, and this can kind of sometimes be confused with white matter disease, demyelination, and other things, again, depending on whether or not the patients have been pretreated. You can also have really rapid tumor growth. So this is a patient with IDH mutant astrocytoma that within 9 months, it rapidly kind of devolved and grew quite substantially, and we had to do something about it relatively quickly. This is a recent study that's going to be coming out, published in Neuro-Oncology here in the next month or two, looking at patients who got biopsies at initial presentation and then got a second surgery. So we have matched tissue. Some of them, all of them had tumor growth. Some of them transformed to a higher grade. Some of them were the same grade, they just had growing tumor. And the take-home message, and again, this is a lot of data, the take-home message really is in astrocytomas, areas of contrast enhancement that emerge, really fast growth rates, higher tumor burden in general, and lower sphericity, meaning that they're more irregularly shaped, really characterize malignant transformation in astrocytomas. In terms of oligodendrogliomas, it wasn't as obvious. A lot of these features maybe weren't present that we would intuitively kind of ascribe to transformation. Contrast enhancement can occur. It was less of a predictor because oligodendrogliomas can have little bits of enhancement even at grade 2, as well as large tumor burden. So the larger the tumor, the more likely it has transformed. If we look at astrocytoma grade 4 versus grade 2 and 3, which again, where does something become malignantly transformed is kind of controversial. Again, it's the same kind of characteristics that we would expect with astrocytomas if they're contrast enhancing, if they're very rapid tumor growth, if they're very large, or if they're less spherical in shape, then they're more likely to have transformed over time. So fortunately, we do have some treatments that do have responses. So unlike glioblastoma, where we're just always watching these things just grow uncontrollably, in IDH mutant diffuse gliomas, we do see treatment responses or stability. So this is a patient treated with an IDH inhibitor. You can see the pre-treatment 2.5 years before to the baseline, the second slide over, or the second panel over, you can see that the tumor has definitely grown over those 2.5 years. At the start of treatment, you can see at year follow-ups, it's actually starting to slow down and actually shrink a little bit over time. And so we used growth trajectories early on in the development of these IDH inhibitors to really understand on a patient-by-patient level, are we seeing drug effects in these patients? And you'd be surprised that a large proportion of patients included in our clinical trials in general don't have rapidly growing tumor coming into these trials. So that can really muddy the water or obscure any kind of treatment effects we want to see in these patients, particularly if we're looking at progression-free survival or stability, right? Because if they have stable tumors coming in and they're stable over a long period of time, it's really not very informative. But we were fortunate to have some patients where we saw rapid tumor growth that then either stabilized or shrunk, again, on these IDH inhibitors. So we use these growth rates and alterations in growth rates as a tool, a patient-by-patient tool, to really understand if the IDH inhibitor, or any treatment for that matter, is really having an effect. And so this is plotted data that we already saw in table form from the Indigo trial. This is ensemble average of each of the groups. So these aren't patient-specific growth rates. But you can see on the panel on the left that there was a slight difference of the pretreatment growth rate between the vorasidenib and placebo arms, even though they were randomized. But what you can see is after treatment, there clearly was divergence of those growth rates, where placebo in general just kept growing, and vorasidenib on average really did plateau and kind of stabilized or stopped tumor growth. This same effect size was seen in the patients that crossed over. So it really didn't matter whether or not we treated them up front or we treated them at crossover. They still had the same change in tumor growth rate or that mechanism. And then you can see, again, the progression-free survival data on the right that then reflects that. So there are some limitations, as many of you are probably aware, of anatomic MRI. So just tracking these tumor volumes over time, we can be misled. One of the main things, and you're all very familiar with this, dealing with this, is treatment effects or pseudoprogression. This is thought to represent sort of an exaggerated therapeutic response. Cytokines are released. You get an increase in vascular permeability. It appears to be more common in MGMT methylated patients, although that's still a little bit controversial. And there's a possible relationship between the presence of pseudoprogression and a better prognosis for the patients. I would say that this phenomenon of pseudoprogression is pretty ill-defined. It's kind of a circular argument. We only know if it exists after the fact. Imaging-wise, the definition really is an increase in contrast-enhancing lesion size, followed by subsequent improvement or stabilization without any change in treatment. Pathologically, there is no consensus over what pseudoprogression is. It's really the presence of gliosis, reactive cells, without any evidence of viable tumor. As many of us know, that's hardly ever the case. Our pathologists, at least, will always see something happening and never call pseudoprogression per se. And as you can see, there's really a spectrum of treatment-related changes that you see, and it's really a mixture of both active tumor as well as treatment effects in these patients. But there are some tools that we can use, maybe not a single tool to differentiate them, but some tools that we can use to kind of understand what's going on in these patients. The first is perfusion MRI, specifically dynamic susceptibility contrast perfusion MRI. It's the most widely available or the widely used perfusion technique for the brain. The idea is you acquire dynamic MR images during the ejection of contrast. It's acquired between your pre and post contrast T1 weighted images. And then from those images, you calculate a relative cerebral blood volume. And studies have shown that this measurement of this relative blood volume really correlates on a histologic scale to vascular density. So it's the number of vessels per cubic millimeter. And this adds value not only looking at after radiation or after changes looking for pseudoprogression, but also particularly in these IDH mutant gliomas looking for malignant transformation or really indicating tumor progression. So this is a patient, this is supposed to be a little bit of an animated slide, but a patient with an IDH mutant glioma that is shown over time after 4 months, after 6 months. The lesion really hasn't grown much, but perfusion actually in this deep white matter area has actually blossomed, and it really is looking very aggressive. This is a serial panel, again, of a different IDH mutant glioma showing baseline, then at 2 years, then at 2.5 years. So you see the flare images on top. Not a lot of changes volumetrically, not a lot of changes in terms of the features that you see. But in the relative blood volume maps at the bottom, you can clearly see that area of T2 hyperintensity filling in with hypervascularity. This patient then went on to have confirmed transformation to a grade 3. And so with that same cohort, this study that I mentioned that's going to be coming out in neuro-oncology also looked at diffusion and perfusion changes to see if these help us differentiate between transformed and non-transformed patients. And so what we found was that in astrocytomas, lower apparent diffusion coefficient trended towards those that had malignant transformation. But higher cerebral blood volume in those patients did indicate transformation. In oligodendrogliomas, there was no difference in diffusion or perfusion, and so between grade 2s and grade 3s, imaging-wise, can be very difficult to differentiate in oligodendrogliomas. Again, with astrocytoma grade 4s, the same trends, lower ADC indicating maybe a more hypercellular tumor, as well as higher cerebral blood volume indicating a hypervascular tumor, both indicators of a grade 4 versus lower grade astrocytomas. And so there are standard protocols for acquiring DSC perfusion for use in clinical trials as well as clinical practice. You can see here it's put in between, during your sort of incubation time after the injection of contrast and the acquisition of your post-contrast T1 weighted image. Again, the guidelines are published and have been used in some trials moving forward. The second and the last tool that I'm going to talk about really is amino acid PET. This is a mainstay, I would say, in Europe. They have a lot easier access to some of these agents than we do in the United States. It's thought that this identifies the most active portion of the tumors. There's a variety of them available. There's C-methionine, tyrosine, FET PET is most commonly used in Europe, and then F-dopa PET is also, all of these act through that LAT1 transporter. And the LAT1 transporter is upregulated in most of these sort of cancers, particularly gliomas, due to a variety of mechanisms. And again, this is highly debated and not completely fleshed out, but used in proliferation, used in transamination, transmethylation, as well as using it for fuel as well. And you can just see in these images down at the bottom the added value of amino acid PET, looking at your non-enhancing tumor and where potentially are the most aggressive areas of those tumors. And so amino acid PET uptake has been correlated pathologically with Ki-67 labeling index. So the higher the uptake on amino acid PET, it seems the more aggressive and the higher the mitotic activity of those tumors. Here you see, some of the values. So here's a baseline image. A year later, you do see some interval changes in the flare images there. The F-dopa PET, nothing appreciable happening within that area. Half a year later, you can see nothing really changing on the anatomic imaging, looking a little fuller maybe, but no dramatic growth. And you can see the F-dopa PET in this case now is very avid. Here's just another example here at baseline. You can see an area of kind of residual uptake. And then you can see a year later, you can see even that posterior aspect of the resection cavity now has avid uptake and not a lot of changes on your flare images. So again, this is a way that amino acid PET can really add value to anatomic imaging. There's been a variety of consensus recommendations and use cases for when and how you're supposed to use, or you can use amino acid PET. One being post-surgical residual disease. So I think a lot of people use it for surgical planning as well, but also as an indication of what's residual disease. Sometimes it can be, and you'll see from some of the case studies that we'll look at, can be difficult after surgery to understand what's gliosis, what's demyelination, what are these changes. And so amino acid PET can really help us differentiate where is there highly metabolically active tumor that may be left behind that may look like some of these other phenomena. This is an example of FET PET, again, being used in Europe, looking after IDH inhibition. And while uptake generally is low in IDH mutant gliomas, early evidence, at least from this study, suggests that metabolic volume and things decrease after IDH inhibition. So again, speaking to that mechanism of maybe slowing the tumor down, maybe reducing the proliferation index in these lesions, and it seems to correspond with uptake in PET. This is an example of FET PET after chemotherapy. Similar reduction in PET after chemotherapy. Again, as you might expect with a responding tumor. And again, some recommendations for using FET PET after chemotherapy, improving delineation of radiation targeting and things like that. There's also some indications for radiation planning, and I know there's a couple of clinical trials that have been done in the past by the Mayo Clinic and others, using, in this case, F-dopa PET as well as FET PET to really define the planning volumes There's ongoing clinical trials as well to look at using FET-PET or using amino acid PET for treatment planning for radiation. And again, there's been this paper that came out a few years ago now, really rationalizing when to use amino acid PET, when it's useful, at first initial presentation, after surgery, before radiation for radiation planning, after radiation to maybe see treatment effect. And again, this is an ever-evolving field. More evidence keeps coming out as well from our colleagues. So in summary, standard anatomic MRI does a really good job in monitoring these patients and really is the cornerstone of monitoring IDH mutant gliomas. We can perform these MRI scans over the course of many, many years to monitor these things. Quite often you can't do that with amino acid PET, for example. Contrast enhancement, often absent in low-grade gliomas, tends to emerge with malignant transformation, particularly for astrocytomas. Growth rates critical for both monitoring progression and monitoring maybe any changes in these patients, but also for looking at treatment response, particularly in IDH inhibitors that tend to stabilize the tumor as opposed to dramatic shrinkage, as we saw and talked about. Perfusion MRI reflects vascular density. Again, can be useful for detecting malignant transformation or identifying changes that may occur that you're not capturing with the anatomic MRI. Amino acid PET, there's a variety of tracers available. Again, not all the time is it reimbursed in the United States, so some of it's not readily available. Uptake tends to correlate with proliferation rates and tumor activity, and uptake seems to reduce in response to IDH inhibition and positive treatment response from radiation or cytotoxic agents. So these can be useful for those patients. Thank you.
Okay, so we're going to move on to our first tumor board, and this is an opportunity to get feedback from and interaction from all of you, both in the room and online. And again, I encourage you to go to the app. So our first case, which we're going to call the patient Mr. J, a 38-year-old who developed focal seizures and some cognitive changes, was started on anticonvulsants. I'll just emphasize that the cognitive changes had some mild expressive aphasia and overall a performance status of 1, so slightly decreased performance status due to these cognitive symptoms. Patient underwent MRI, had a approximately 6 centimeter T2 flare, hyperintense lesion in the left frontal temporal lobe. No enhancement in the post-contrast scan, and you can get a sense of the volume. There was a little midline shift and involvement of some language adjacent areas on functional MR. And we're going to hear more about surgical resection in a few minutes, but there was a surgical intervention that attempted maximal resection as usual. Subtotal resection was achieved, so about 40% of the volume was removed due to the proximity to language centers. Imaging revealed, as you see there, about 28 cubic centimeters out of the 47. T2 flare still showed quite a lot of hyperintensity. Pathology, IDH mutant tumor. This was a non-cotyleded tumor, as is typical in a astrocytoma. We see ATRX, P53. In this case, MGMT was methylated. Okay, so the first polling question, and again, please use the QR code to join. Online, you're already joined, and be prepared to answer this question. What treatment strategy would you prioritize for Mr. J following the surgery? A, watchful waiting or observation. B, begin IDH inhibitor treatment. C, start chemotherapy with either temozolomide or PCV. D, start radiation. E, start radiation with a plan for adjuvant chemotherapy. Okay, so here's the results. Thank you for those that voted. Not surprisingly for the radiation oncology audience, we see 42%. The highest number is for starting radiation and adjuvant chemotherapy. The second highest was the IDH inhibitor. There was some lower enthusiasm for single modality treatment using classic cytotoxic treatments. And nobody in the recommended observation, only in this patient with a decreased performance status due to cognitive changes and substantial residual tumor. Do I advance this one? Oh, no, you do. Okay. We're going to get some feedback from our panel, but let's do a few more questions first. Mr. J completes radiation, gets a good response with stable disease at 3 months. Given that his tumor was IDH mutant, what would be your approach to molecular therapy integration? Option A is continued observation. B, start IDH inhibitor as maintenance for 6 months post-radiation. C, wait for 6 months after radiation, then consider IDH inhibition as required from the situation at that time. D, start the IDH inhibitor with a plan to continue for 2 or 3 years. Okay, so interesting. The number one choice was to start the IDH inhibitor and continue for 2 to 3 years. Number 2 was to observe the radiation response and consider as needed. And then the other option was upfront IDH inhibitor as maintenance. Interestingly, the lowest score was observation. Before we go on, I just want to ask Dr. Veller, any comment on the options here?
I think the most important option is missing. The most important option would, for me, be PCV, because this patient had progressive neurological decline owing to the tumor. So I don't think that this is a space for vorasidenib. I think upfront radiation followed by PCV is the treatment of choice in that setting.
And just before we move on, anybody else want to comment on that?
No, I agree with Dr. Veller. Overall, we don't have the data yet about the IDH inhibitor in sort of the maintenance phase and with chemoradiation. I think this is an important question, like that they have clinical trials and would encourage that because it could be very helpful, but we just don't know yet.
I would say that we do have some anecdotal data from the phase 1 data that enrolled the recurrent patients, and some patients respond, in terms of having stable disease after they failed other things. But I think you're right, the jury's still out in terms of a randomized trial of, how big that effect is, what proportion of patients really see a benefit.
Do I advance this? Yeah, okay. Okay, we were doing that. I'm just looking to see. We do have a question from the audience. The question is, do you see a role in combining radiation with vorasidenib in the context of residual or recurrent disease? Does anybody want to comment on that? So this would be, I'll clarify a potential scenario. So this is someone who was maybe observed up front and now has progression, and maybe a tumor board decide, okay, there's definitely progression here, we're going to do radiation, and or maybe they got upfront. I'll make it even more interesting for Dr. Veller. They got upfront PCV or temozolomide. Someone decided we'll give them upfront temozolomide. Then they were observed for a while. Then they progressed. The decision was made to do radiation. What would you combine with vorasidenib in that context?
I wouldn't, because there is no data. That is a classical question for a clinical trial. I think this trial is more or less done in the US, whereas the Europeans do the IDH inhibition after completion of treatment, but this patient is stable with radiation, so I don't see a need for something experimental there, because how are you ever going to say that your intervention has helped if in the first place the patient is stable with radiation?
And just to add an imaging question, if you have a patient like that, so a patient who's progressed, you mentioned things like amino acid imaging, but a lot of centers don't have that, other than, say, at least in the US, other than, say, yours and Dr. Berger's, who do it routinely. What would you say to other centers is the one thing you might use, in addition to anatomic imaging, to help you make a decision as to, say, you're in that tumor board deciding whether it's time for salvage radiation?
And it's a grade 2 from the beginning?
Yeah.
So if you haven't done serial imaging in terms of perfusion, I would add perfusion, maybe spectroscopy, to understand, is there an aggressive component of it? Because many times if you add on some of these therapies, part of it might respond a little bit, or part of it may stabilize, but the more aggressive part might not. So that would be my recommendation, just given the tools that you have already at your disposal.
Eric,
Yeah.
I'm going to need to make a comment.
I need you to.
It's difficult to sit by and have a scenario like this where we presume there's progression and we haven't even discussed the option of reoperation. Not only that, but in the first scenario, the first thing we would ask, and I know a lot of radiation oncologists, if they saw a patient like that, would say the same thing, is, has the patient had a maximal safe resection? Because, there's a lot of variability in achieving that throughout the country. And a lot of it has to do with how many of these cases you do, what your experience is. So when you see somebody who's had only a 40% resection, I think the first thing we would do, certainly our neuro-oncologists, our radiation oncologists would come to us and say, look, do you think you could do more of a resection? So here's the first myth. We do not say anything is inoperable or less operable because of preoperative functional imaging. We have been burned on this numerous times. We don't use fMRI, we don't use resting state. If we think it's in an area that we could do more of a resection, there's no question we would go back in and we would do it. In this case, it would have been an awake operation to try and really understand, interrogate during surgery whether or not there is functional tissue or not. And in many circumstances, in at least 80% of cases that we get referred patients who are said to have inoperable lesions, when we operate, we can always do a much more aggressive resection. And as you'll see from some of the slides coming up, that it's not just about 100% or 90% resection. We make differences in outcome, even if we can get much more than 50%, 60% resection. So that's the first thing you should ask. In this case, if Ben could tell me, I'm not sure this is progression, but it's changing. Patient hasn't had radiation, because there's a great article in the Journal of Neuro-Oncology this month from a radiation oncologist, I think it was from Vermont, where they showed that after radiation therapy, if the patient had radiation therapy, that even though the responses were pretty significant in the majority of those patients early on, they then saw changes on the flare, which resolve in the majority of those cases. And the cut point seems to be about 15 months. So you can see, even after RT, you can see changes that look worrisome for progression. And if we can't sort that out with some kind of an imaging protocol, then sometimes we have to sit tight in those patients because it could start to regress. So these are complicated issues, and I think everybody's got to weigh into this. Is it a reoperation case? Is it not? Do we have imaging that can really nail this down? Even with chemotherapy, RT, or even with IDH inhibitors, sometimes we have to just sit tight. We don't know what's going on. So it depends on how much progression there is. But
how frequently are you seeing post-IDH inhibitor treated patients that have progressed, and then you're able to do another safe maximal resection on those? And then what is the adjuvant treatment to that you've seen?
Well, we're gaining more and more experience with IDH inhibitor failures and reoperating on those patients. And so in that setting, we would not hesitate to reoperate. Again, it all has to be safe. It has to be safe, and we have to do it safely with the techniques that we have, but we would not hesitate to go back in and do that. The other thing to keep in mind is that these tumors are like chameleons. They change color. They change molecular signatures. They're very heterogeneous. Many of these do not continue to be the same thing that they were the first time. So you can go back and reoperate on them. They pick up different mutations, which can give you clues about, what they're doing and how they need to be treated. But the answer is we go back in. We would go back in and reoperate.
Great, and we're going to have more chance in a minute to talk about surgery. So this is our second case. So now a 42-year-old woman, also with seizures, but no other neurologic deficits. Also treated with anticonvulsants. Performance status better than the first patient. Preoperative imaging showed now a 4.2 centimeter lesion in the right frontal lobe. Again, non-enhancing, smaller volume. I won't even talk about the functional MRI. And attempted maximal safe resection. And now I'm going to hand over to Dr. Berger.
Yeah, well, I had a couple of slides here, I think. I don't know if it's after Leah's. Yeah. And I'm not going to bore you with the details of the surgical piece of it, but this is that article that I published in the Journal of Clinical Oncology essentially was about a 20 plus year career type of study, which I wanted to really look at over time in patients, typical patients who had molecular characterization. So they were IDH mutated. They either had an astrocytic genotype or an oligodendroglial genotype, with a 1p19q, et cetera. But what we showed is that not only can we get patients out 20 years, we're not talking about progression-free survival, I'm talking about overall survival. But not only can we do that, but if we do what we now refer to as surgeons as super complete resections, where we go beyond the flare, when we can do that safely, we call it a gross total resection plus, we can push that survival curve higher and higher. And I think that's very consistent with EANO, although I won't speak for Michael, but I think that's clearly the feeling for SNO, EANO, ASNO, that maximal safe resection, if done properly to the point where you're getting beyond or to the margin of the flare or beyond, you can push those survival curves, past 2 decades and beyond. And we've looked at this, we've validated this with groups outside of ours in San Francisco. And again, you can see the hazard ratios continue to be affected in a positive way, even if you can't get a complete resection. So if we think we can do complete resection, great. And that goes for incidentally discovered cases. I don't know about where you all are from, but in this part of the country, a week does not go by, I don't see a patient who had a Prenovo scan and has a lesion. I've operated on 3 of those patients this month who had incidentally discovered asymptomatic lesions that were characterized on imaging very clearly to be low-grade gliomas. We don't sit on those patients because we did an international study showing that incidentally discovered gliomas that are operated on before they become symptomatic do much better in terms of overall survival and progression-free survival than if you wait until they have a seizure. So there's another group that benefits from that. And then just a point about the RANO Resect group, which I'm a member of, Dr. Weller's a member of, where from an international consortium point of view, where we're looking at 1,000+ patients in these studies, and then determining class 1, class 2, class 3, class 4 types of resection, class 1 being super total beyond the flare, and then all the way down to biopsy. You can see the survival curves are commensurate with class 1 more aggressive resections. So again, as surgeon, this is my last point. I just wanted to say that we have really some very good sophisticated tools. Intraoperative MRI is the least useful tool for me because it's never about anatomy, it's about function. And we have ways intraoperatively now to find microscopic disease using Raman spectroscopy, which is FDA approved and commercially available, driven by AI platforms that tell us during surgery within 90 seconds of getting a piece of tissue whether there's tumor or not. So the world has changed for us. We can be much more aggressive and we can be safer to it. So that's really the only point.
I'm going to just add, not everyone will have Dr. Berger in their tumor board, but as radiation oncologists, it's important to understand when we can speak up in a tumor board and say, could you consider more resection? Because it will definitely impact the recommendations we will subsequently make for subsequent therapy. So, and it's useful to know the tools available, even if we're obviously not doing the surgery. This is from this case, and you can see the residual T2 flare, but still much better resection than the previous case. The pathology came back again as a IDH mutant astrocytoma, and now ask you, what treatment strategy would you prioritize for this patient after the surgery? A, observation. B, IDH inhibitor treatment. C, chemotherapy alone. D, radiation alone. Or E, radiation with planned adjuvant chemotherapy. Okay, so I think it's actually a very interesting result. So if we look at the top two, 28% saying observation and 24% IDH inhibitor treatment. Let me just ask Dr. Berger, that was obviously it's just a theoretical case, but that slide, that post-up slide, what's your comment on the residual tumor there?
Well, residual tumor, because of the use of an intraoperative MRI, is very different than if I went in and I mapped that motor cortex and I found that the tumor clearly stimulated and was functional, then that would be the end of it. But if this case was brought to me, I would first go to Ben and I would say, Ben, okay, how much of that flare is real? What can you tell me about that? It looks like only the back end is a residual lesion. So if it came to me and the surgeon did it asleep and didn't do mapping, I would say, let's go back in and map it out and try to take that piece out. Because if I could, then we could be in a watch and wait mode. We wouldn't even have to do anything in that setting.
Okay, I'll ask now, Dr. Veller. First, you can, let's go into the assumption that Dr. Berger went back in and is convinced that maximal resection is achieved and there's really no significant residual. And these are the options. What do you think you would do?
I think on the bottom of your previous slide, you said that she's not completely normal neurologically, right? She had some dysarthria or something.
Very mild.
Yeah, mild, whatever. If I have mild dysarthria, for me, that is a case that needs something more than surgery. With all respect for Dr. Berger, I don't think that dysarthria goes away by surgery. How should that work? I mean, I don't think that. So, I mean, in principle, that could be a case for IDH inhibition, but only with very, very close monitoring, I would say. And I would make it dependent on the neurological symptoms. And if they still persist and a little bit worse, then it's again a case for you, I would say.
I think we have to be a little cautious here because dysarthria doesn't come from this area. So I'm not convinced that it's dysarthria. If somebody said to me, their foot's a little weak, I would say, yeah, okay, I would buy that. But dysarthria, no.
Good point, because I think the image didn't correlate with the case well. So let's say the foot's a little weak.
Right.
Okay, let's do that. Anyone else want to comment now on the treatment? Alice, Dr. Alice, where do you stand on that?
Yes, well, I think because this is mild, I think this is something that we would discuss either way with the patient. I think overall, if there are symptoms that are, you are very concerned are going to get worse and are really impacting the patient functionally, then we would start radiotherapy and chemotherapy. But I think this patient with the mild symptoms and overall IDH inhibitor treatment could work out with watching very closely, like Dr. Veller said.
And let's get in the weeds a little. You say close up, when Dr. Weller was saying close observation, how close?
We generally start by watching a little bit more closely every 3 months at first, because as I think about it, we get to know the tumor and then go out to every 6 months more indefinitely. But I think opposed to the first case where you had a lot of symptoms and the aphasia, that is a case where I'd really think about radiotherapy. This one, I think you have a little bit more leeway.
And Dr. Ellingson, what about imaging as you're doing that close observation?
I mean, I think you're trying to look for that tumor growth, and if it correlates with any changes in the symptoms as that kind of posterior part probably plump up. So the close monitoring is also radiographic monitoring.
Sorry, I pushed it twice. Make sure it doesn't advance. Okay, question 4. Mrs. K got IDH inhibitor therapy. After 4 months, MRI shows no reduction in residual tumor. What step would you prioritize next? Continue the inhibitor. That was A. B, add radiation while continuing the inhibitor. C, stop the inhibitor and start radiation followed by chemotherapy. D, stop the inhibitor and repeat surgery. E, switch to chemotherapy alone.
Are we saying it's shrunk, not shrunk, meaning it's
Yeah.
stabilized?
Stable.
Okay. Not growing.
Not great.
That's correct.
Right.
Okay, you know there are radiation oncologists in the audience.
Fine.
So more than half said add radiation, but continue the IDH inhibitor. And the next highest was just continue IDH inhibition for with stable disease. Who wants to comment on those 2 options?
I will. So based on my experience, sometimes in these patients, you can't tell if it's stabilizing or you're going to see a treatment effect for up to 6 months after starting the inhibitor. Also, stable disease is, is sort of the outcome that you expect for successful inhibition, especially if it's growing before. So I would say keeping the IDH inhibitor is not necessarily failing in this circumstance.
Very good point. I'm going to move on just because we have a couple other questions to get to, and I want to make sure we have time to get to an important audience question. Okay, question number 5. Now, 18 months later, now we're seeing some enhancing areas that have progressed, new mass effect, cognitive decline, and again, this is Mrs. K staying on the IDH inhibitor, but flare remains stable. Advanced imaging suggests transformation. What next? A, continue IDH inhibitor. B, add radiation while continuing IDH inhibitor. C, stop IDH inhibitor and start radiation and chemotherapy. D, stop IDH inhibitor and repeat surgery. E, switch to chemotherapy alone. People are listening, Dr. Berger.
Well, I mean, first of all, you got to know what's going on here. Even somebody as good as Ben Ellingson can't always tell you it's transformed. So, I mean, the presumption is it has, but you certainly want to go in and do a resection, get tissue, do molecular sequencing, really understand what has happened here.
But I guess if this is the same patient that couldn't get more surgery and it's grown in that area,
Well,
what's the,
and if it's grown out forward, it depends on where it grows, right? If it grows forward, it's growing away from the motor system. And if you don't see progression in the motor strip, then you could go in and take out that exophytic component and stop when you find function. But the key is to get tissue here. So.
All right. I think we have one more question. I'm going to hand this over to Dr. Ellingson.
So she didn't do any of those things. She got concurrent chemoradiation, and then at her follow-up 6 weeks later, new areas of enhancement along the right paraventricular space are noted within the radiation field, minimal mass effect in that area. The volume, but the enhancing volume is doubled in size, again, along that paraventricular area. Minimal to no mass effect. In fact, the ventricles have grown. Perfusion and amino acid PET are cold. She doesn't have any new symptoms. What would you prioritize next? A, continue to monitor, repeat the MRI with perfusion, plus or minus PET, every 4 to 6 weeks. start a different chemotherapy, repeat surgery, or D, repeat radiation treatment.
You can comment on this.
No, I think that's reasonable. I think quite often we've got a series of case studies where we see that paraventricular enhancement. It can actually move, it can get larger, it can get smaller, it can move all over the place. And the key is looking at all those different features and kind of what they add up to. Obviously, it was an idealized case, but the mass effect is a big thing that's really hard to quantify that you can see with your eye. And if that ventricle is getting larger, even though you're seeing enhancement, no other changes, then yeah, continue to monitor and see what's going on. Or repeat surgery.
Yeah, no, I would monitor. I would go for the first choice.
Excellent. If anybody has questions online or in the room, use the app. I have some here I'm going to get to. Oh, great. So the first one, and I'm going to modify it a little bit, so I apologize to the person who asked. The first one is, how do you counsel patients about the use of vorasidenib? And it's a couple of parts. One is, someone should comment on if it's a young woman in childbearing years, how do you counsel them? And then, in addition, how do you counsel, given the uncertainty of what overall survival impact this treatment is going to have, and perhaps in the context of whatever the PFS benefit is compared to placebo in the pre-selected patients from Indigo? So how do you put this in context to a patient, both the potential challenges if you're a woman of childbearing age and how to interpret it in terms of survival? Who wants to take a stab at that? Dr. Veller, I'm looking at you.
Well, it depends a little bit what the need for treatment is, but it is clear that the recommendation is not to get pregnant under treatment. So if it is clinically justifiable, I would say enforce your family planning and then look at the IDH inhibitor in 2 or 3 years. I think you have to make priorities. And then, of course, should it not be a wise decision, there is still repeat surgery, radiation around, so there are options. But we cannot recommend to go on the IDH inhibitors if the family planning says we need a child.
Mm-hmm.
And what about the context of the OS? We don't know the OS benefit. So what do you tell patients if they say, well, will I live longer on this drug versus getting another treatment, an alternative treatment?
I think the argument for vorasidenib at the moment can only be maintaining neurological function, preventing progression, which I think in this disease trajectory is still something to gain for. We just heard before that this is also what early radiation does, but I think it's worthwhile.
I think also we know from some of the studies that you guys cited, but some various other ones, people that have looked just at case studies and single institution data have shown that if you can slow those low-grade tumors down, it does translate into survival benefit, particularly in those that you're able to watch and wait and do those things. I know we've been burned as a field with bevacizumab, and I think that haunts the FDA even to this day. And so I think it's yet to be determined, but I think the mechanism of action is such that unless they come back even more aggressive, you might expect that a PFS benefit would translate into a survival benefit.
We're down to our last 45 seconds. I'm not sure I think we've covered some of these questions in other contexts, so I'm not going to get to them. I'll just make some concluding remarks. And first, I want to really thank this panel for their very helpful insights, really amazing discussion, amazing comments. also want to thank the Medscape organizers for really putting together a fantastic program. I think if the one thing I would take home as radiation oncologists is be active in your tumor boards, speak up. You may know an answer that even others in there who are not radiation oncologists may not have thought of. So that's the purpose of Tumor Board. Lastly, point out that this is part of an online set of resources available from Medscape as part of the Contemporary Glioma Care Innovation, Collaboration, and Transformation Program. So again, thank you very much for attending and participating.